My name is Oralia Gomez Ramirez. I am a postdoctoral research fellow at the University of British Columbia and the BC Center for Disease Control. I want to thank the organizers of the GARD 2020 virtual conference and the chairs of the Epidemiology and Public Health track for the opportunity to present in this venue. Today, I will talk to you about a research project we have been conducting in British Columbia that lies at the intersection of implementation science and digital public health, particularly as it relates to the implementation of internet-based testing for sexually transmitted and bloodborne infections, or STBBIs. Before I continue, I would like to acknowledge my co-investigators and co-authors in this work, as well as our academic and public health partners and the funders of this study listed on the slide. I have no conflicts of interest to declare. Digital public health services can help strengthen STBBI prevention efforts and benefit population health outcomes. Despite the interest in the use of digital tools in public health, we still know relatively little about the social, material, economic, and policy environment or context that shapes their implementation over time. In the literature, there is substantive knowledge base on the science of implementing evidence-based interventions and practices. However, a dominant focus on understanding the early phases of implementation still persists. And so we must pay more attention to the processes involved in scaling up and sustaining a program once it has been implemented. Likewise, in many studies in which the role of context in implementation has been considered, context has often been imagined as a set of separate or easily sliced up factors that are static or constant over time. To address some of these pending questions, we are investigating how healthcare organizations can roll out digital public health services. Our study aims are twofold. One, to learn what it takes to sustain and expand GetChecked Online, or GCO, in the province of British Columbia. And two, to understand the role of different contextual factors, such as policies, geography, service organization, or socioeconomics, in shaping the ongoing implementation of GCO to date. Here, I want to briefly mention that a parallel study is being conducted in Ontario, looking at the opportunities for the implementation of a service like GCO in a different healthcare system. Check out the GAR e-poster listed on the slide. What is GetChecked Online? GetChecked Online, or GCO, is an internet-based testing service that allows users to test for syphilis, chlamydia, gonorrhea, HIV, and hepatitis C, infections that are transmitted sexually or through the blood. You can learn more about GCO in the links or references listed on the slide. But here I will mention that GCO users can test for STBBIs without using the real name and are not required to provide personal health numbers to access testing. GCO is a publicly funded service provided by the BC Center for Disease Control and is integrated with STI clinical practices at the center. GCO is then a virtual extension of the in-person provincial STI clinic. Preparation and consultation for this work, or for this service, started in 2009. The service was first launched in Vancouver in September 2014, and since then it has had two scale-up waves. One in 2016, when GCO was introduced in 5 new communities outside of Vancouver, and a second one in 2019, when GCO was launched in 1 more location, also outside of BC's Lower Mainland. For this study, we employed the critical research strategy of institutional ethnography, which has a long history in critical healthcare and HIV research, and it draws our attention to people's everyday work processes and how such processes are socially organized. We draw on qualitative data collected between April 2019 and February 2020. We conducted 25 individual interviews with healthcare and social service stakeholders involved in the implementation of GCO and or in the development, scale-up, and sustainability of other STI prevention and testing services in BC. We also observed 21 planning and operations meetings regarding the ongoing implementation, operations, and adaptation of GCO. During the course of the interviews and observations, several documents were identified by participants as relevant to their work, and we undertook a review of some of those key texts. We employed an inductive and iterative analytical approach to identify work processes and implementation timelines, shaping the scale-up and sustainability of GCO. We found that the organization of the public health and healthcare system and the implementation of HIV-specific strategies shaped the ongoing scale-up and sustainability efforts of GCO. In particular, the Seek and Treat for Optimal Prevention of HIV/AIDS project, also known as STOP HIV, was identified as a major public health policy, allowing the first scale-up of GCO from the lower mainlands and into communities located in the regional health authorities of islands and interior health. Interviewees identified the testing strategies and the funding provided to implement the STOP HIV project as pivotal in the ability to introduce GCO in communities outside of Vancouver. The STOP HIV initiative promoted HIV routine testing, which made it easier for regional public health managers to make the case for the introduction of GCO in their jurisdictions. Additionally, the STOP HIV project came with a funding envelope from the BC Ministry of Health for implementation of the initiative across the province. This enabled the hiring of dedicated staff to manage and oversee the rollout of programs, in this case GCO, that will help meet the established targets and milestones outlined in the 2012 From Hope to Health strategic framework. Our research also uncovered that GCO's first scale-up occurred against the backdrop of health system reorganization, particularly in the area of sexual health. When GCO was first introduced to communities in the regional health authorities, some of their health authority-run STI clinics had been closed down for over 4 years, since the end of 2011. Interviewees identified this as a service vacuum, a situation in which nobody owned STI services within one of the health authorities. But this also helped position GCO as an internet-based service, which could help begin filling in this wider service gap. While the STOP HIV program enabled the first and second waves of scale-up of GCO to initially 5 communities and then 1 more community, the program's scope also hindered the ability to further scale up the program to more communities outside of Vancouver in 2019. The STOP HIV program primarily sought to increase testing and treatment for HIV. An interviewee suggested that STOP HIV sought to foster the testing for HIV together with other health issues affecting the communities with highest HIV burdens. However, the program promoted testing for HIV when testing for other STBBIs, but testing for other STBBIs when testing for HIV was left out of its scope. The limitations posed by a policy that was HIV specific became evident during the ongoing implementation of GCO when interviewees mentioned that it had taken over 2 years from first scale-up for a first HIV positive result to be detected through GCO. And also when over time, it became increasingly clear that other STI infections had high positivity rates in GCO. Additionally, interviewees identified both the HIV-specific focus of the strategy and the operational funding remaining steady since 2016 as contributors to this divergent outcome. The budget for the implementation of a STOP HIV program had not been increased since 2016, despite growing testing volumes. In short, HIV-specific policies enabled the scale-up waves of GCO, but the absence of a comprehensive STBBI strategy that allocates funds for testing beyond HIV, financially and conceptually, has also limited the expansion of GCO to more communities. In conclusion, our study revealed the broader provincial context has shaped the ongoing implementation of digital public health services in BC. Our findings point to the healthcare system and public health policies as contextual determinants of implementation, and our study contributes to understanding the contextual factors shaping implementations once they have been successfully introduced and as they unfold over time. In the case of GCO, the organization and reorganization of sexual health services and the rollout of HIV-specific initiatives have both helped and limited the implementation process over time. While a dominant focus in existing implementation studies has been put on the early phases of implementation and on context as a discrete or a stable variable, our study underscores the need to investigate the later and ongoing phases of an implementation process and to understand the context of implementation as it shifts over time. I close up with an acknowledgement to the funders of this study, as well as the members of the Community Advisory Board and our team's research members. Our contact information is listed on the slide. Please contact us if you have questions or comments. Thank you.